This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, I'm Stacey Clardy from the Salt Lake City VA and the University of Utah, and today we're going to go through an in-depth update on myositis. This is part 2 of our 2-part series on myositis. And the last episode, please take a listen. We started out with some of the basic review that we needed, including what does myositis mean in the modern era? What are the major categories? It has changed a lot over the past several years. And how do we make that diagnosis? What's the most efficient way to diagnose it in the year 2025? Today, we're going to jump more into treatments, some cases, complex real-world experience cases, and what the future holds in terms of research for myositis. And so who better to walk us through that than Andrew Mammen. Andy is the senior investigator and leader of the muscle disease unit at the NIH's National Institute of Arthritis and Musculoskeletal and Skin Diseases, NIAMS for short. He's also adjunct professor of neurology and medicine at Johns Hopkins and co-founder of the Johns Hopkins Myositis Center. Speaking of treatments or treatment trials and where we are with the different types of myositis, have there been any major changes in the last 5-10 years?
I wish there were more, but to be honest, many of the drugs we were using 10 years ago, we're still widely using as first-line treatments today, and we still use a lot of drugs off-label. Now, every patient is different, and all of our treatment decisions are going to be highly individualized, but there are some general principles about treatment that were true before and are still true, and also some new things. So in general, for a newly diagnosed myositis patient with mild to moderate disease, except for inclusion body myositis, most of us are still going to be using corticosteroids and an oral agent like methotrexate, mycophenolate, or azathioprine right out of the gate. And the idea is, of course, that as the oral agent, the immunosuppressive agent is starting to do its job, that we'll be able to taper the corticosteroids. Now, in a patient with more severe disease, for example, one that has dysphagia or difficulty ambulating, I'd probably also start IVIG at the outset. And adding IVIG would also typically be a good move in a patient with milder disease on steroids and another oral agent who's getting worse or who doesn't get better after a month or two on the corticosteroids and the steroid-sparing agent. As you may know, there's a recent trial of IVIG in dermatomyositis, which demonstrated its efficacy in that disease, and that actually led to FDA approval for that indication. IVIG is now FDA approved for dermatomyositis. Rituximab is another medicine that we still use, and I think of it as a good medicine to add in a patient who hasn't responded as much as we'd like to the combinations of corticosteroids, an oral immunosuppressive agent like methotrexate, and IVIG. But it's important to keep in mind, and I'm sure this is probably true for other neuroautoimmune diseases, it can take weeks, sometimes 6 to 8 weeks to actually take effect. So it's not going to be an immediate response like corticosteroids. There are also a few special cases and some new drugs that are worth talking about here. The first thing is that we now know that interferons, particularly type 1 interferon, play a significant pathological role in dermatomyositis and the antisynthetase syndrome. So Janus kinase inhibitors, JAK inhibitors like tofacitinib and baricitinib, which target that pathway, they seem to be pretty good for these diseases, although we don't have the kind of evidence like we now have for IVIG. So not all the data is in yet, but it wouldn't surprise me if JAK inhibitors become more of a first-line oral agent in dermatomyositis and the antisynthetase syndrome, particularly as the newer generation versions of JAK inhibitors come on board that are more targeted to the type 1 interferon pathway and have less what I would consider off-target effects. There are also a couple situations in which I would even now advocate for starting or adding a JAK inhibitor right away. The first would be the anti-MDA5 positive dermatomyositis patient with rapidly progressive interstitial lung disease. There was some preliminary evidence published a couple of years ago in the New England Journal suggesting that JAK inhibitors may lead to improved survival in those patients compared to other medications. So that's one. The other is a dermatomyositis patient who has active and progressive calcinosis. So that's where they get these calcinosis deposits under their skin. They can erode through the skin. They can become infected. They're very painful. And they can really be a major problem in dermatomyositis patients, and especially in those who have anti-NXP2 autoantibodies. And in my own experience, JAK inhibitors are the only drugs that I've seen that have stopped that process in its tracks. So that's the other time when I would go directly to a JAK inhibitor. So there's some other sort of unique situations. Anti-HMGCR positive myositis is one of those where there's increasing acceptance that IVIG is particularly good for that disease. And many of us will use it as a first-line drug, sometimes even as monotherapy in patients who have anti-HMGCR positive myositis. Some people will start steroids plus a steroid-sparing agent like methotrexate plus IVIG at disease outset. Sometimes I'll just use IVIG, and that often works well, although ultimately I usually add a steroid-sparing agent other than IVIG. In the case of anti-SRP positive myositis, rituximab seems to work particularly well. I don't know why, but it does, and others have noticed this as well. So we often use that as part of the initial therapy because those patients are often very severe at the beginning. We'll start rituximab along with corticosteroids and an oral agent in patients with anti-SRP. And I guess one of the last things I'd want to mention is that we now think that many of these types of myositis may be antibody mediated. And so I guess it's not surprising that CAR T therapy has been reported to work in some very refractory myositis patients. CD19-directed CAR T therapy or BCMA-directed CAR T therapy, both of those are potent B-cell depleters. And there are patients who've failed rituximab, IVIG, you name it, who have had pretty durable medication-free responses after getting B-cell depletion with CAR T therapy. That's something that is mostly only available in clinical trials at this point, but that or some other potent B-cell depleter may turn out to be the magic bullet that we're looking for our refractory myositis patients.
That's helpful. And you're alluding to the fact that there are some trials ongoing. If we hit the clinicaltrials.gov.
Yes.
Go ahead. Yeah, tell us about those.
I won't mention anyone particular by name, but there are a couple that are going on. Some are specifically for myositis. Others include patients with several different rheumatic diseases, including myositis. But you can find them on clinicaltrials.gov. And I have referred a couple of my super refractory patients to those trials because I think that they are pretty promising.
Good to know. We always need hope and ideally more data.
Yes, we do need more data. The jury's still out on those, but that's one of the promising avenues of treatment that's out there on the horizon.
Okay, let's do lightning round of cases where I just pick your brain. Okay, if I give you a 55-year-old woman on a statin, presents with proximal weakness, her CK can be, mildly elevated. What's the fastest way to get this woman a diagnosis?
A patient who has proximal muscle weakness or complaints of proximal muscle weakness with an moderately elevated CK, you're certainly thinking a myopathic process. And you threw in there that she was on a statin, and that may be important. But a lot of patients over the age of 50 are on statins, so I'm not going to jump to any conclusions about that. So the first thing is I want to get more history. How long has the patient had the weakness? If it's been years rather than weeks or months, I'm thinking about inclusion body myositis, which affects more men than women, but it can affect women as well. Or I'm thinking about a genetic muscle disease if it's been going on for years. That's going to be on my list. I'm a neuromuscular guy, and I'm going to be asking questions about whether the weakness is fluctuating. Do you have double vision? I'm fishing for suggestions that they might have a neuromuscular junction defect. And I'll probably be checking for myasthenia gravis if the answer to either of those is yes, because you can have both myositis and myasthenia gravis. And we've have probably a dozen or so patients with myositis and myasthenia gravis, and the latter is often missed. So you'll probably want to test for the appropriate serologies, to get a rep stim test and that kind of thing if they answer yes to those questions. The other thing is, I heard about statins, but are they taking any other myotoxic medications? For example, colchicine. In that case, a toxic myopathy due to statins, another drug, or the combination is definitely going to be a real consideration. And then this is really important. I'm looking to see or ask about other extramuscular disease manifestations. So do they have a rash? If they have a classic heliotrope or Gottrin sign, that's really diagnostic of dermatomyositis or the antisynthetase syndrome. I should say that antisynthetase syndrome rashes can look similar, if not identical, to dermatomyositis. I'm also going to want to look at the palms of their hands. Why would I do that? Well, Gottrin sign is usually on the extensor surfaces of the hands in dermatomyositis patients, but in anti-MDA5 positive patients, these ulcerating lesions, sometimes called reverse Gottrons, are on the palms. So if you see a rash on the palms of the hands, you're really thinking about anti-MDA5 dermatomyositis. I'm also going to be asking about pulmonary symptoms. Do you have a cough? Do you have shortness of breath? Those two things are typical features of interstitial lung disease, which you can see in patients with the antisynthetase syndrome or anti-MDA5 positive dermatomyositis. And then on my exam, after I've asked all those questions, I'm looking for features that are potentially suggestive of a particular disease. Do they have eye closure weakness? Do they have deep finger flexor weakness? Both of those would make me suspicious of inclusion body myositis. As neuromuscular folks, we're looking for scapular winging, which I was taught as a fellow is something that we just see in genetic muscle disease, but you can see that in immune-mediated necrotizing myopathy as well. So we have anti-SRP patients who definitely have scapular winging. So don't let that fool you. I've asked more questions. I've done a physical exam, and there's lots of different ways that this could go. But let's just say that the patient only has proximal muscle weakness. A CK, you said it was mildly elevated, under 1,000, I guess we're talking about, and in the context of statin use. And let's say they don't have any extramuscular manifestations and they don't have fluctuating weakness. Although statin-triggered autoimmune muscle disease with anti-HMGCR autoantibodies would still be on my differential, it's super rare for those patients to have a CK under 1,000 when they show up in the clinic. So I'm thinking with a mild CK elevation, less than 1,000, that's less likely than other possibilities. I would, in that case, start by stopping the statin and stopping any other potentially myotoxic medications. And if the CK goes down and the weakness resolves after a few weeks, then I'm going to think this is likely a toxic myopathy from one of those medications. In this case, maybe it's the statin. And the question is going to be whether to re-challenge the patient to prove that's the case. And that's a whole nother discussion. If the CK doesn't go down, then I would definitely send a myositis autoantibody panel to include testing for HMGCR and SRP. So those are immune-mediated necrotizing myopathies that usually do not have extramuscular manifestations. If the same patient had presented with a higher CK, 1,000 or more, I would have sent that autoantibody panel right away. At least I would have sent the anti-HMGCR test right away. Now, if the autoantibody panel comes back negative and the patient isn't getting any worse, that's when I'm starting to think about genetic muscle disease. I'd probably send genetic testing at that point before I did a muscle biopsy. And if the sort of standard gene panels were negative in the patient that you just told me about, I'd also want to make sure that I sent genetic testing for type 2 myotonic dystrophy, which can present like this with mild to moderate CK elevation and proximal muscle weakness. So that would be my general approach to that patient that you described.
What I love the most about that answer is I tried to get you to diagnostically anchor and you went in the total opposite direction, refused to anchor. I love it. Let me ask you another case. And this is one that I see in my CNS clinic, a couple similar patients. They come to me with neurologic complaints. My job is usually to figure out if those are primary or secondary to a rheumatologic process. They often they get into the clinic because they have one or two positive rheumatologic antibodies, and they aren't fulfilling criteria for the condition associated with that antibody. And so most often, this ends up being, in my case, RNP. So they don't fulfill criteria to check the boxes for lupus. The referring clinicians are saying, I know there's something going on here. I don't know if this antibody is related or not. I will often see them, and sure enough, they're weak and they have other pieces, just not enough to make a diagnosis. Usually, in my experience, again, the CK tends to be normal or really not exciting. Maybe, 400 or something. What do I do with those patients?
That patient does have an autoantibody, so RNP, and that can be associated with myositis in the context of lupus often. But as you said, some of those patients don't fulfill criteria for lupus. If the patient has an RNP autoantibody and myositis, say based on a muscle biopsy, then depending on who you believe and what classification criteria you like, those patients might be diagnosed with mixed connective tissue disease, for what that's worth. But I don't think that really helps you to call it that. I think that the point is that there are patients who have autoimmune disease that involves the muscle that cannot be classified into something like lupus or scleroderma or one of those 6 forms of myositis that I described. And I would consider those to be nonetheless a type of overlap myositis. And from a practical point of view, you're going to treat them like your other myositis patients with corticosteroids and a steroid-sparing agent and perhaps IVIG or rituximab if necessary. But because of their status with the RNP antibodies and having some extramuscular manifestations, you're going to want to make sure that you are screening periodically for interstitial lung disease, which can show up in RNP positive patients, and nephritis, kidney involvement in those patients. So that might be something different that you need to do in those patients. And then there's no right answer about the exact treatment strategy. I would suggest sort of the usual treatment strategy. So I don't know how helpful that answer was, but I think that's because we don't really have good answers for those patients. If we think it's autoimmune, we're going to treat it like it's autoimmune. We're going to immunosuppress them. We're going to be on the lookout for complications, but we're a little bit in the dark. Some of them seem to have a disease all their own, if you will.
And I will say many of the ones I've treated have responded, which has been reassuring in that the weakness halted, maybe had a chance to respond to then physical therapy and things. But it's tough. And in many of them, maybe they have this slight bump in their creatinine, or I get the chest imaging and they say, oh, they might have had an infection recently. Yeah, they're just these patients where they can never quite meet the criteria for a lot of things.
You mentioned the imaging. One thing that I would mention, just a word to the wise, is that when you are screening for interstitial lung disease, and I didn't know this as a starting out neuromuscular person, you want to make sure you order high resolution chest CT without contrast and not just a standard chest CT, because that's really the test you need to do to exclude or not that the patient has ILD.
Right. Yeah. The only reason I knew that was from the neurosarcoid world. Same sort of approach. And I guess I've been using that for everybody, but good to know that it's right. So along those lines, when someone comes in, separate from your exam, let's say you're not even allowed to do an exam. We're on telehealth here, an in-person exam. What are the things that a patient says? Maybe you're in your general neurology clinic. You're not in a muscle clinic. What keywords should I be listening to, or what specific 2 or 3 questions should I be asking to make me think myositis?
So the first is how long they've had it and the rapidity of onset would be one of the things I'd be looking for. Trying to distinguish between perhaps a genetic muscle disease and myositis, which tends to be a subacute or acute presentation. The other thing, and we've talked about this a little in other contexts, is are there extramuscular disease manifestations typical of rheumatic diseases? Except for inclusion body myositis and immune-mediated necrotizing myopathy, which are pretty exclusively skeletal muscle involvement, patients with myositis like dermatomyositis, the antisynthetase syndrome, overlap myositis, they almost always have extramuscular manifestations. So I'm going to be asking about rashes. I'm going to be asking about cough and shortness of breath. And I'm going to be asking about joint involvement. Do they have joint pain? And does it sound like an inflammatory arthritis? So those are some of the key things I would be asking about. And so a patient with neurogenic things are not going to have these extramuscular manifestations. Patient with genetic muscle disease, they're likely not going to have these extramuscular manifestations. So I find that to be very helpful. I'm talking to a patient on the phone and they say, I'm weak, I've got a rash, I have a cough, I get short of breath, and my joints hurt. I'm like about 90% sure they have the antisynthetase syndrome. If only life were that easy all the time. Yeah, those are the kinds of things that I ask about. And also in the patients who have weakness, another big one that I just harp on, symptoms that would suggest myasthenia gravis, like fluctuating weakness, bulbar weakness, especially if it's fluctuating. And so those are super good questions to ask as well.
That's great. And I will say you've unlocked a bit of a new fear for me. I don't think about autoimmune fasciitis that much. I'm thinking about it since you just mentioned it.
Yeah.
Since we've been talking, I've heard of an eosinophilic form. I don't want to go too far astray, but we need to know. So tell me how I diagnose that.
So you can have fasciitis with or without myositis. And the one that you don't want to miss is the one that is without myositis, because without myositis, you may have no muscle weakness, a normal EMG, and a normal CK, and you're only going to make the diagnosis based on muscle MRI. You'll probably want to then, after you see that there's these thick and stir hyperintense fascia, you'll want to do a fascial biopsy, because you're going to want to see, is it eosinophilic fasciitis or is there some other process going on in the fascia? And then the clue that you might get that it's fasciitis is the CK is normal, but their aldolase is sky high. And for reasons I don't understand, high aldolase is one of the features of fasciitis. So that would be a tip-off that you should look for fasciitis by MRI, and then again, get a biopsy of that fascia if that's what it shows.
Do we ever get lucky and see a slight elevation of the peripheral absolute eosinophil count? I always feel like I won the lottery if I see that and then diagnose EOE in somebody.
Yeah, in a patient with eosinophilic fasciitis, you're going to see tons of eosinophils in the blood as well. So that definitely would be a tip-off. And some of those patients have eosinophilic esophagitis. Some of the patients will have that along with fasciitis of the muscle.
That's helpful. And then we treat it as we do the eosinophilic conditions, probably as a primary approach. Is that what you do?
I've only seen a few cases of this. I think that the rheumatologists see more of it than we do, but the ones I've seen have melted away with corticosteroids and then sometimes require methotrexate over the long term. But I tend to refer those patients to rheumatology if they are not pretty straightforward to treat. And then the other question I have, which I don't know the answer to, is whether you have to look for malignancy in those patients. I think that you may.
Yeah, that makes me wonder. There's treatments approved now for EOE, so I wonder if you don't get a twofer. It would be interesting to see. And you also mentioned a couple minutes ago inclusion body myositis. So just for my own where to file this in my brain, I'm going to make you put your nickel down. So is it immune-mediated or neurodegenerative or both, or which one starts first?
Stacey, are you trying to get me in trouble here? So what I'll say is it depends what year you ask me, and that I don't know. What I can tell you is that there are very smart people, smarter than me, who know more about inclusion body myositis than I do, who disagree on this point. I very much respect Steve Greenberg, who thinks this is predominantly an autoimmune disease, and he's done great work demonstrating that as a significant component of, in all likelihood, of what's going on, and has identified a particular population of CD8 positive T cells that seem to be the ones damaging muscle fibers, and and there's an ongoing clinical trial of a drug, a monoclonal antibody targeting that. So we'll see whether that is the primary driver. I also have enormous respect for Tom Lloyd, who you may know, who would tell me, no, actually, inclusion body myositis is a consequence of of abnormal processing of mRNA with cryptic exons and the generation of proteins that the body doesn't usually see as a result, and that it's predominantly autoimmune. And he has a nice mouse model that suggests it's predominantly an autoimmune disease. So both of these guys know more about IBM than I do. Both of them are smart and have come to opposite conclusions. It's also possible that they're both right, that it is both an autoimmune and a degenerative muscle disease. But unfortunately, the jury's still out. And really, unfortunately for our patients, we don't currently have effective treatments for inclusion body myositis. So I generally, as a general rule, don't offer them immunosuppressive therapy, although there's some controversy around that as well. No, you didn't. I think you didn't trick me into making some bold claim about whether IBM is autoimmune or a degenerative process. And maybe you'll have a podcast where you can get a couple of people who disagree on that, and you can do a little back and forth.
Yeah. Great idea. And not meant to trick you, but I always do wonder how to explain that one. And I find myself talking out of both sides of my mouth. So good to know that the jury's still out, and another one where we'll have to keep checking clinicaltrials.gov all the time. We have an equivalent of this actually on the CNS side, right? It's our Iglon-5 antibody, where it seems to have flavors of both. And these are probably the ones we'll learn the most about everything from, but they sure are tricky. Along those lines, tell me what I have to look forward to in the next 5 years. What I really want is to not have to use steroids for any of these patients before I retire. So where are we headed? What's the current focus of research?
If one thing is hopefully clear from what we've talked about so far is that autoantibodies, the myositis-specific autoantibodies, really define different clinical categories of myositis. And so if I know what myositis autoantibody a patient has, I know a lot about their clinical features and what the prognosis is and so on. And we've also known for a while that the levels of myositis-specific autoantibodies, at least in some of the cases that have been studied pretty closely, are very well correlated with disease activity. For example, in anti-HMGCR myositis, the higher the anti-HMGCR antibody titer, the weaker the patients are, and the higher the CK levels are. And it's true for some other antibodies as well. And when patients go into remission, drug-free remission, it's also accompanied by the autoantibodies going away. So I've always been intrigued by the idea that the autoantibodies themselves might be pathogenic or contributing to pathogenesis. But we always thought that since all of the targets of the myositis autoantibodies are intracellular, either in the cytoplasm or the nucleus, that these antibodies really couldn't have a pathogenic effect like they do in, say, myasthenia gravis, where the target is extracellular. But it turns out that antibodies can get into muscle cells, and that antibodies accumulate in the same subcellular localization as the target of the autoantibody. So an example would be anti-HMGCR autoantibodies target HMGCR, which is in the cytoplasm. If you stain for immunoglobulin, there's tons of immunoglobulin in the cytoplasm of HMGCR patients and none in the nucleus. In contrast, if you stain muscle tissue from a patient with anti-MI2 antibodies, so the MI2 antigen is in the nucleus, you see the antibodies accumulating in the nucleus and they're nowhere to be seen in the cytoplasm. So the antibodies seem to be going to where the target autoantigen is. And there is now emerging evidence that they actually cause dysfunction of their target autoantigen. And there are several examples of this. We've shown it for a couple, but I want to emphasize the anti-HMGCR story because I think it's now making a lot of sense how those antibodies work. So anti-HMGCR autoantibodies, a group in France recently showed that they get into muscle cells and that they inhibit HMGCR enzyme activity just like a statin does. And so we know that statins cause myotoxicity by blocking HMGCR activity, and we now think that the anti-HMGCR antibodies do the same thing. They inhibit HMGCR activity. And there are parallel stories for many of the different myositis-specific autoantibodies. So I'm saying this because all of this goes to further suggest that the myositis-specific autoantibodies play an important role in the pathogenesis of the disease. And now, as we're starting to read case reports coming out from patients who have received B-cell depletion with CAR T therapy, that those patients who've been refractory to lots of other treatments have gone into drug-free remission when their B cells are fully depleted. That also contributes to the evidence that the antibodies made by the B cells are having a pathogenic effect. You might ask, why does rituximab not work as well? And we think it's probably because the cells that are making the antibodies are in the lymph nodes and bone marrow, where rituximab has been shown not to be good at depleting the antibody-producing cells, whereas the CAR T therapy can go in and wipe out the B cells and plasma and other cells that are there making the antibodies. That's my long-winded way of saying B cell depletion may turn out to be an effective therapy because it's getting rid of the myositis-specific autoantibodies. Will we still be using steroids in 5 years? Probably in 5. We'll still be using corticosteroids, unfortunately. Hopefully we use them for shorter periods of time and at lower cumulative doses. I think we can already move in that direction now that IVIG is approved for dermatomyositis. And now that we have the JAK inhibitors at our disposal, a lot of our patients require much lower doses of steroids. There's a lot of other stuff going on in myositis, but I did want to highlight that story of the potential pathogenic role of the myositis-specific autoantibodies.
It's such an important story. And again, immediately draws me to the parallels we see in CNS autoimmunity. And what I've taken home from this is that everything I learned in immunology several years ago about rules where immune cells could have an effect and where they could get to and where they could go has really been thrown out the window.
Yeah, it is amazing how things can change. So hopefully those new insights lead to new treatment strategies that can help us take care of our patients better. And the group that really suffers, of course, are the inclusion body myositis patients, because we just have no treatments for them. I'm really hopeful that we do get some effective treatment for that disease in the upcoming years.
This has been fantastic, Andy. I feel like I'm caught up.
I'm glad. I hope so. Like we talked about, every patient's different, but hopefully this provides some sort of framework for thinking about these patients, which ultimately I find to be pretty satisfying patients to treat because we can make so many of them so much better. And so it's very rewarding to treat them.
I want to thank you. And again, I've been speaking with Andrew Mammen, Senior Investigator, Leader of the Muscle Disease Unit at the NIH's NIAMS. We really appreciate this. This has been so practical, so helpful to me, reassuring in some aspects and also broadening my differential diagnosis in others. So I want to thank you again for your time.
It's been my pleasure. We can hopefully talk again in another 5 or 10 years and see what's new.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.